In the modern era, cataract surgery has evolved to become a refractive surgery. In our quest to leave our patients spectacle-free, we encounter two common pitfalls. Of all variables in biometry, effective lens position is the only one that can't be measured preoperatively. Toric IOL rotation is a major cause of suboptimal visual outcomes, and the cylinder also depends on the ELP. Capsulotomy fixated IOLs overcome these problems. Bag in the lens IOL requires a posterior capsulotomy, whereas the masket IOL has a peripheral groove in which the IOL is captured. The Femtis lens with 4 additional haptics is designed to clamp into the capsulotomy. All these designs, however, require a perfect 4.8 to 5 mm rexus, preferably using femto, and cannot be used in complications. In 2016, Dr. Sri Ganesh had a simple idea inspired by the swiveling kickstand of his motorbike. The Swivel Haptic Capsule Fixated IOL was invented and initial results published. We now bring to you a new modified version of the Swivel Haptic IOL. It is a single-piece open-loop hydrophobic acrylic toric IOL with a 6 mm optic, a 360-degree square edge, an overall diameter of 13 mm, and 2 extra haptics at 3 and 9 o'clock position made of a proprietary material, Swivel, over a pivot. The IOL with all 4 haptics is injected into the bag, after which the Swivel haptics are opened over the anterior capsule using a Sinskey hook and a dialer. Let us now look at the lens in action in various surgical scenarios. A normal, uneventful case. Here, a 4.8 mm femtocapsulotomy has been made. The swivels are always rotated and checked before loading the lens. The swivel haptics are placed on the optic longitudinally, and the IOL is loaded into a back-loading cartridge. A butterfly cartridge can also be used to load the lens. It is inserted into the bag along with the swivel haptics, and using 2 instruments, one from the side port and one from the main port, the swivel haptics are rotated over the anterior capsule. The IA probe can be easily directed under the IOL to evacuate the viscoelastic. The lens is well centered and on the intended axis. It shows no rotation on post-op day 15 with an uncorrected vision of 6/6. Next, we have a case of manual capsulorhexis. Here, during femtocapsulotomy, the patient suddenly moved and hence it was incomplete. It had to be completed using a rhexis forceps and was slightly irregular and slightly larger than 4.8 mm. Here we see that the capsule is still easily captured by the swivel haptics, and this goes to show that a femtosecond laser is not mandatory to use this lens. Intraoperative OCT shows the surface of the optic and swivel haptic lie just beneath the iris. What do you do when you have a PC rent when a toric IOL is planned? Note the large peripheral posterior capsular rent. The IOL is injected into the anterior chamber over the iris, and the swivel haptics are gently opened on top of the intact anterior capsule margin. The other 2 haptics are carefully folded and tucked beneath the intact rhexis margin. The continuous rhexis margin allows us to fix the lens to the anterior capsule. Even after opening the swivel haptics, the IOL can be rotated into the intended axis. A stable lens on axis is seen post-operatively. Can a toric lens be implanted without capsular or zonular support? This is an aphakic eye where the 0-180 was manually marked, based on which the intended axis was taken using the Callisto system. 2 markings are made perpendicular to the intended axis for the swivel haptic fixation. A clear corneal incision and 2 side ports are made, and the swivel haptic IOL is inserted into the AC over the iris. 1.7 mm from the limbus, a 27 gauge needle pre-threaded with 6O proline is inserted. The proline suture is grasped with a forceps, threaded into the hole on the swivel haptic and exteriorized through the main incision. The end of the proline suture is then flanged using a Bowie cautery. The other end of the suture is pulled up to put the lens in place. The same procedure is repeated on the other side where the proline suture is threaded from top to bottom on the hole at the end of the swivel haptic and flanged. Note that during all these steps, the IOL haptics remain above the iris and in the anterior chamber. As the proline sutures are pulled upwards, the swivels open up and the IOL comes into the intended axis. The IOL haptics are then tucked beneath the iris. The external proline sutures on both ends are cut and flanged. This is a modified 4-flange technique performed using a toric swivel haptic IOL. So why use this lens routinely? Let's look at some of the advantages. It ensures a good rotational stability in toric IOLs. A femtosecond laser is not required to use this lens. It shows better centration and less tilt, and no special instruments or training is required. Ultrasound biomicroscopy shows a relatively anterior and fixed effective lens position, leading to more accurate biometry, better refractive outcomes, and less negative dysphotopsia. When a toric IOL is planned, it can still be used when complications such as PC rent, zonular dialysis, or aphakia occur. The possibilities with this lens are endless. Let's look at what's in store. A multifocal design. Due to an anterior ELP, the near ad would be reduced, meaning fewer rings and less dysphotopsia. Femtocapsulotomy can be centered to the visual axis, and multifocals can be used even in patients with large angle alpha. So whatever the need of the hour, be it a monofocal, a stable toric IOL, a multifocal, patients with large angle alpha, complications such as PC rent, vitreous loss, aphakia, or zonular dehiscence, the swivel haptic IOL has got you covered. One lens for all seasons and for all reasons.